Hi dear students, this is Dr. Shruti, your pathology faculty from Medicoz community. So the big question, how was your exam? How was your NEET entrance exam 2023? I'm sure all of you would have done well. So when we communicated with the students, most of them said the difficulty level ranged from moderate to a real difficult level. Very few students told me that ma'am, it was easy. So one thing that we saw, at least when it came to pathology, was most of your questions were from your high yielding topics. So there was no new topic totally, but all your questions were framed from the important or a high yielding topics, right? A little unfair because you had like 2 questions from renal, about 3 from hematolymphoid system. So if you had left revising these main topics, main chapters in the end, then I think you would have fumbled a little bit. Otherwise, we found the questions were quite direct, and going with the current trend, they had asked a lot of clinical based questions and a lot of images were being shown to you, and that's how it's going to be your exams. So they're taking the trend more towards a clinical based question scenario, and where you have to diagnose and where you plan the next, they're going to assess you how you're going to manage the patient, right? So that's the thing. So I think in the next few minutes we'll be revising these questions, recalling and revising, and also please when you're with me in this lecture, please also type in the options, because you were the guys who actually sat for the exam, you have seen the options. So this would not only help you to like revise, but also would help the next progeny of PG aspirants for them to face the exam, right? So please type in the chat box what you feel. If you feel that this was not the option was something else, or there was some addition to the question, then please type it in, okay? And finally, congratulations, all of you have successfully completed your PG NEET entrance exam. So that's a big thing. You've all given your best in the last few months and done this. So don't worry, don't be tensed about what you're going to face and how the results are going to be. So for now, remember, it's over, and upcoming INICET or for any other exam, just prepare with a positive mind. I'm sure all of you have done well, and this hard work never goes for a waste. So you will all get a good result. Okay, so let's move on and recall the questions now. So hi students, let's move on with the questions now. So we have the first question. So this is a 25-year-old male patient, okay, and this patient is presenting with a low Hb and a low platelet, okay. So this was what was asked. The Hb was also low and the platelet was low, and he also has gum bleeding now. So there is bleeding, and he has a raised PT and aPTT. They had given peripheral smear. Now there is some confusion. Some said, ma'am, this was peripheral smear. Some said that was a bone marrow aspirate smear which was given. Anyways, so this was the smear and it is shown below. Okay, so now you have to arrive at a diagnosis and you have to tell what translocation was seen. Now, they've already told you it is an AML here. So they have not given a total count. Okay, what was the total count? They haven't mentioned here, but of course what you can see here, it's a smear with blasts, okay, and it's an acute condition where you are finding a lot of blasts, and so you see these big round cells here, so these are your blasts, okay, and what do you see? They have a raised nucleocytoplasmic ratio and they have some granular cytoplasm, unlike your lymphoblasts. So these are myeloblasts. Anyways, they've already told you because all the option had AML, I believe. Okay. If these were not the options, then please type in what you feel the options were. Okay. So now let's see the options. So options. So this question is telling you that it's a young chap with a gum bleed and with a raised PT aPTT. So they're asking you to mark AML with translocation 15-17. So this is the right answer, AML M3. Why so? Because if you see over here, this particular person is presenting with a gum bleed, that is a hemorrhagic diathesis, and the person has raised PT aPTT, which means he is in BIC. Okay, so and you know very well that it is your M3 which is associated with DIC. Let's see the other options. You have AML with MPN gene mutation. You have AML with inversion 16, that is your M4. and you have your AML with translocation A21, which is your M2, that is AML with maturation. Okay, so this is again a question from your very important topic. Okay, so you cannot miss out on the FAB classification, and you cannot miss out on what is the important translocation associated with which histological type, with which morphological type. Okay, just a quick revision here. So this was your option associated with AML M3 associated with translocation 1517. Now what is this translocation? Translocation of PML and RARA alpha fusion. So what you are seeing, what you saw in the previous slide, so all these were your promyelocytes. So your APML or acute promyelocytic cells were seen with OR rods. And what do you see these rods here? Okay, so these are your OR rods. Okay, OR rods. It's also whenever it comes, so other options, students, it was AML with NPM mutation. Now NPM stands for nucleophosphomyl, and this NPM gene mutation is seen in about 20 to 30% of adult AMLs, okay, and to about 10 to 15% in child AML. Why is this important? Because they have found out a targeted therapy. Now in the year 2017, the entire classification of your acute leukemias was based on molecular mutation classification. Okay, so then they have found out that there is one entity called as MPL with NPM mutation, and this mutation is important because if it's found, you have targeted therapy, and automatically whenever there is a good treatment, this becomes a good prognosis AML. Okay, so the other options you had was AML with inversion 16. Now AML is with inversion 16 is your M4, can be associated with eosinophilia. Remember this, can be associated with eosinophilia again, and also they can present as a chloroma or a myeloid sarcoma. So you need, when it comes to AML and FAB classification, you need to know which types present with gum bleeding, which type is associated with chloroma, which types have, or this cytochemistry is seen by which cells of which type, and which type is associated with DIC. This DIC was your question, your M3. Okay, why do these cells why do these patients present with DIC? Because these blasts on their surface have a procoagulant. Okay, so this procoagulant is released and it presents as a procoagulant state in the body, resulting in DIC. So they present with acute hemorrhage. They present with diastasis, like the person might present with cerebral stroke, the person might present with pulmonary embolism. So all sequels of DIC is what they present with. Okay, so if the question is asking you raised PT, aPTT, remember they are asking you to mark AML which is associated with DIC. Okay, I think this question is clear. Now we'll move on to the next question, again a hematology question. This was a child. Now I want you people to type in the chat box, was the history saying a child or it just said a patient? Okay, now this presented with the jaw swelling, and flow cytometry shows translocation 814. Okay, this was the translocation which was seen, and they had given, so there is a little discrepancy. Was it a biopsy of the jaw lesion? Was this the picture, or was it a bone marrow aspirate picture? We are not sure. Now this is a BMA, bone marrow aspirate picture, where you can see a lot of these atypical cells. These are all B lymphocytes, large B lymphocytes, okay, atypical cells with, what do you see here in the cytoplasm, students? You see a lot of vacuole, right? So agar ye tumhara nucleus raha, then you can see a lot of vacuole, these empty spaces. Okay, all these are lipid vacuoles. These are lipid vacuoles, and this is lipid vacuoles, and this is a case of Burkitt's lymphoma. Why? What are the other hints? This is a child. So Burkitt's lymphoma is a childhood tumor. Okay, childhood hematological tumor. And jaw swelling. Usually Burkitt lymphomas are seen in head and neck and in the jaw. Okay, and classically they have told you there is translocation 814. Again, a very it's a very important high yielding topic, and I've just chosen a direct question from there. If they've mentioned you the translocation and they're asking you the option, then I think it's like a one-liner for you. Okay, it's Burkitt lymphoma. Remember, it is, if some said, ma'am, it was 822. Even 822 is involved in Burkitt lymphoma. Okay, but 821 is AML. AML, M2. Okay, so be careful as to what. So Burkitt lymphomas usually come with 8 and they come with even numbers. Okay, so that is the translocation of your c-Myc and immunoglobulin heavy chain. Okay, so coming to Burkitt's lymphomas, just a quick recap. It's a highly aggressive non-Hodgkin cell lymphoma. It's a B-cell lymphoma, and this is what you see on your biopsy. This is a biopsy picture. Say it said a jaw biopsy showing this, and you see all these blue cells are your lymphoma cells. Okay, and these are your tingible body macrophages. Okay, tingible body macrophages. Why? Because this is a highly aggressive malignancy, right? Highly aggressive मतलब बहुत divide और multiply हो रहे cells. अगर the cells are dividing and multiplying, then all these has to be ingested by your macrophages. Okay, all the apoptotic bodies of the cells are taken up by your macrophages, and this gives rise to an appearance which is called as your starry sky appearance. Again, this can come as a question, so I'm just highlighting starry sky appearance. Okay, and if you go back to the picture, this was your lipid vacuolations. Now this is also seen when aspirate is done and seen, you see this lipid vacuoles, which are again positive for a stain called as oil red O stain. Okay, these are all lipid vacuoles which are positive for oil red O. So the about Burkitt's lymphoma, it is associated with Epstein-Barr virus. This is again important, and the classical translocation is your translocation 814, that is between c-Myc and IgH on chromosome 14. So 814. Two types, endemic type. Also some students told me it was an African child in the history. Whatever said and done, they were asking you to mark Burkitt's lymphoma. Okay. And there are two types, endemic subtype and sporadic subtype. Now the endemic subtype associated with African children usually present with jaw swellings, or they present with head and neck swellings. Whereas your sporadic type usually presents with abdominal swellings. Again in children and young adults in Western countries. Okay. So when it comes to Hodgkin's, your appearance, translocation, association with ABV, highly aggressive lymphoma, endemic subtype in places where neo-endemic of malaria exists. Okay, African children and otherwise also children and young adults, and starry sky appearance. All these are catchwords for Burkitt's lymphoma. Next, if you would want to rule out the other options, okay, could it be a follicular lymphoma? It couldn't have been a follicular lymphoma because you are not seeing follicles here. Okay. Could it be multiple myeloma? Again, multiple myeloma has a lot of plasma cells. So the cells would have been like this, with the eccentrically placed nuclei, and plasmablasts with the eccentrically placed nuclei like this. Okay. So this could not be that. Moving on to the next question. So this was a child, and this child was brought to the hospital with icterus and pallor. Okay, so this child has anemia and jaundice. That's what they're telling you. And the peripheral smear was shown. Now there is a slight confusion whether the question said microspherocytes. If the question said microspherocytes, then this automatically becomes autoimmune hemolytic anemia. Okay, and the option would have been, the correct answer would have been AIHA and direct Coombs test. But you had spirocytes, a lot of spirocytes here, and the question said it's a child and it didn't mention anything about microspirocytes. So they were simply telling you that this is a case of hereditary spirocytosis, and the next line of investigation you do is osmotic fragility test. Okay, so that is the test for hereditary spirocytosis. So the answer here was HS and osmotic fragility test. All of you are aware Hereditary spherocytosis is a hemolytic anemia. It is a inherited hemolytic anemia. Patient presents with anemia, jaundice, a child, gallstones are usually seen. Again, if the history said gallstones are seen, again they were hinting you towards this. Two types of crisis occurs, aplastic crisis and hemolytic crisis. Aplastic crisis, infections with parvovirus. Hemolytic crisis, you have to remember infectious mononucleosis. I am just giving you the important points for you also to prepare for the next exams. But if you want to add in to whatever recall we have, please type in and please let us know, okay? And what are the other investigations which is done? So usually you do a peripheral smear, you see a lot of spirocytes, and then that is how you go on to do a next test, okay? You don't treat for hereditary spherocytosis straight away just because you're seeing spirocytes. You order for a osmotic fragility test which is done in the biochem lab. Okay, now there is this new thing which is eosin 5 malite test. Eosin 5 malite test, ये क्या है? So this test is a flow cytometric basis test and it is done on your peripheral blood, and it is again this is also a kind of screening test for hereditary spherocytosis. Okay, when it runs, it's autosomal recessive, and I told you it's hereditary, so this acts like a screening test. Okay. So the basic pathophysiology of your cell membrane anchoring proteins and the defect and how it leads to hereditary spherocytosis, I think all of you know. We'll discuss all this in detail when we do individual topics. Now we are just recalling and the questions of NEET PG. Now the next question. So this was a 60-year-old male patient. So this is an old patient, old man. And he's presenting with a total count of 50,000. So the total count for his age is definitely raised. The peripheral smear image is given. What would be the next workup of this patient? So students, what do you see over here? Of course, do you see any neutrophil here? Your neutrophil is a cell which is hypersegmented. Do you see any neutrophil such cells here? No. So you're seeing only lymphocytes. So अगर ये TLC भी है, ये टोटल लिम्फोसाइट टोटल ल्यूकोसाइट काउंट अगर ज़्यादा हुआ है और अगर तुम एक पावर में न्यूट्रोफिल्स नहीं देख पा रहे हो, इसका क्या मतलब है कि he has a lot of lymphocytes. Okay, so he has absolute lymphocytosis. Okay, with lymphocytosis, you are also seeing these kind of cells. And what are these cells? These are your smudge cells. Okay. So smudge cells are also called as your basket cells. Basket cells or smudge cells. Why do these get smudged? Because all these are abnormal cells which are extremely fragile. So when you put a drop on the glass slide and when they spread to make a peripheral smear, all these cells get broken like this. Okay, so they smudge themselves. So these are the smudge cells. Apart from that, you're seeing lymphocytes. Okay, so when you see a picture of absolute lymphocytosis and smudge cells on the smear, usually these patients are also asymptomatic to be. So on a routine checkup, like a person has gone to have a routine surgery or a cataract surgery, and then they send the anesthetist wants a count and the count is raised, and then a peripheral smear is done, then they see that there is CLL. So they're usually asymptomatic, and this comes out on a routine investigation. Now, so what is your question asking you? What is the next step in the workup of this patient? Now, so I have seen this slide, okay, and the pathologist has given a report that it is a hematoproliferative lymphoproliferative disease, okay, most probably CLL. Okay, so what would the clinician do next? What would the hematologist do next? He will order for a stem cell therapy? Of course not. He has to confirm his diagnosis, right? Will he straight away start treatment? No. So option A and D is automatically gone. Now move on to bone marrow biopsy. Will bone marrow biopsy in a case of CLL help? No, it will not. See, it's not like it won't help. Of course, you will see 30% of lymphocytes, okay, and pro-lymphocytes are seen, but on your peripheral smear only, when you do a flow cytometry on your peripheral blood, then the immunophenotyping can be carried out easily for clonality of the cells. So a bone marrow biopsy is not usually required. It can be done with your flow cytometry only. Okay. So because your peripheral blood has so much of lymphocytes that the clonality on these cells can be easily made out, and these are usually B cells and they are CD5 positive, CD19 positive, okay, and so based on your expression, whether it's dim, whether it is, so they're negative for CD79A and they are dim for 20, 22, 23. So all these things, it's a panel which suggests the clonality and will tell you it is CLL. So the correct answer over here is flow cytometry. Okay. Next question. So this is a patient with a creat of 4.5, which means his renal parameters are not good, and he was also positive for hepatitis. Okay. And what can you see? There is a spike and dome pattern on the kidney biopsy. So this is a kind of a direct question, even though it's given to you as a clinical history. This one word, spike and dome pattern on kidney biopsy. So when it comes to renal, it's very important. All your cystic diseases of the kidney and your glomerulonephritis, what you see in all the kinds of glomerulonephritis and your appearance in the light microscopy findings, electron microscopy findings, IF findings, so all these are very important, okay. So the answer over here is membranous glomerulonephritis. So this is the condition, it's an immune mediated condition wherein you see spike and dome pattern on the kidney. Why? Because here there is deposition of antigen antibody complexes on the glomerular basement membrane. Okay, so that is why you see. And where do you see this spike and dome pattern? In the microscope? Yes, which microscope? This is electron dense deposits of spike and dome pattern. This is your spike, it's spiking and there is a dome, okay, pattern, and this is your electron microscopic finding. Okay, it's an electron microscope. So we cannot see this under a light microscope. It's an electron microscopic finding. So whenever a renal biopsy comes, okay, they run a battery of in the pathology lab. They do a biopsy and stain with a lot of stains. Okay, so you usually use the pass stain. Now this is a glomeruli, and here you are seeing a lot of basement membrane, and all these are thickened. So this is again classical of membranous glomerulonephritis. This is a silver stain. Whenever it's black, it's a silver stain. Again, deposition is seen. Now, what do you see here? This is a IF, and you're seeing granular deposition. This word again is important. Granular deposition of IgG class and complements is seen in membranous glomerulonephritis. This is your electron microscopy where you're seeing spike and dome pattern. Clear? So this was again a straightforward question on membranous glomerulonephritis. Let's move on to the next question. This question was very interesting. It was a lung carcinoma. They've already told you the diagnosis. ये lung carcinoma है with large atypical cell, and the patient is also having high serum calcium levels, which means paraneoplastic syndrome is also associated. Now, interestingly, he has a history of smoking for 15 years. Now, here is the catch. Now, when they are telling you there is a smoking history, which means there are two histological types of lung carcinoma which is associated with smoking. What are they? They are your small cell carcinoma and your squamous cell carcinoma. Remember, S for smoking, S for small, S for squamous. Okay? So these are all associated, but the question itself is telling you the person has large atypical cells. Okay, अगर atypical large cells है तो उसको क्या हम small cell carcinoma बोलेंगे? नहीं. So automatically rule this option out. No smoking है, so it's associated with smoking, so it can't be adeno again. Now, large cell carcinomas are not associated with smoking, so you're left with squamous cell carcinoma, and this is the answer. Squamous cell carcinoma. Your small cell carcinomas are nothing but your neuroendocrine tumors. Okay, they are all small blue cell tumors, and they are associated, maximum association of paraneoplastic syndrome is seen. Okay, again, if they are saying high, so paraneoplastic syndrome is usually associated with lung cancer, and that in that your neuroendocrine type or your small cell, oat cell is associated with the maximum paraneoplastic syndromes. Okay, So this is just a picture to tell you that in the Western world, the most common kind of is your non-small cell lung carcinomas, where your squamous, adeno and all these comes. Remember, in the year 2015, the entire lung carcinoma classification was changed into lipidic carcinomas and lot more. Okay, adenocarcinoma, NOS. So we need to do this. I'll tell you all this in detail when we do. But for now, you remember this question was asking you smoking history है और रेस सीरम कैल्शियम है और लार्ज सेल्स है, तो ये क्या है? ओके, सो दिस इज स्क्वेमस सेल कार्सिनोमा वाज द राइट आंसर ऑफ दिस क्वेश्चन. इफ यू हैव एनी doubts or you are not convinced or you have something more to add, please let me know. Next question. So this was a 10-year-old boy and he presented with, so this was a chotu boy who is presenting with recurrent bleeding. So that was the history, recurrent bleeding, and there is a past history of joint pain. Okay, so there is bleeding and joint pain, which means there is bleeding in the joints. And there is no mucosal bleeding. This is also important in the question. When they are telling you there is no mucosal bleeding, which means they are automatically telling you it is not von Willebrand disease. Which coagulation factor deficiency is seen? It's a male, young male with bleeding in the joints. So this has to be hemophilia. The answer is factor 8 and 9. Okay. And it could also be von Willebrand, but they have ruled out von Willebrand, saying that there is no mucosal bleeding. Okay, and you know that if there is hemophilia A, hemophilia B, which is factor 8 and factor 9. Okay, both of these are X-linked recessive disease. So then the history said a boy. And von Willebrand disease, again, this is autosomal dominant. Of course, there are subtypes which are autosomal recessive also, but mainly remember your hemophilias are. Your hemophilia is X-linked recessive and it presents with a factor deficiency. Let's move on to the next question. Now this question again, it's a HIV patient. So again they are giving you a clue. It's a HIV patient with a low CD4 count. The image in the lesion in the mouth is shown in the heart palate. The palate here. Okay, which carcinoma is seen? Okay, which carcinoma? So you know that HIV patient usually associated with Kaposi sarcoma. When the CD4 counts go less, your HbA comes into play and results in Kaposi sarcoma. Now this question, what can you see here? You can see a lesion. This is a nodular lesion. Okay, with a raised violaceous lesion. It's a raised bluish or a violaceous lesion. So that itself tells you that this is some vascular tumor. Okay, so Kaposi sarcoma, students, is your Kaposi sarcoma is a vascular tumor of an intermediate behavior. It's a vascular tumor associated with HbA. Okay, and it is a spindle cell tumor and it has a lot of on morphology. When they send a biopsy, what you can see is a lot of slit-like spaces of the vessels with spindle cells which have a prominent nucleoli. Okay, it is a kind of a spindle cell tumor with extravasated RBCs. So there's spillage of RBCs. So suppose now they've shown you the clinical photo. They can also give you a microscopic photo and ask you. That's why I'm just telling. Okay. Now, if you go back to the lesion, why can't this be a squamous cell carcinoma? What is squamous cell carcinoma? The squamous cell carcinoma is usually a carcinoma where you can see a lot of keratin pearls, right? So your squamous cell carcinoma, you see a lot of keratin pearls, and the squamous cell carcinoma will have ulceration. It will be whitish areas with ulceration, with or without ulceration, most commonly with ulceration. Why this whitish area? Because there is keratin here. Okay, but अगर आप यहाँ पर देखोगे, do you see any white areas? No, right? No ulcers, no white areas. So you can easily rule out squamous cell carcinomas. The other option was basal cell carcinoma. How will your basal cell carcinoma look? Again, that is an important question. So your basal cell carcinomas will usually have a, it's a rodent ulcer. So it's usually ulcerated, rodent ulcer. It will be a little, dark black in color, grossly, and it will be infiltrating and usually around the eyes, the jaw area. So this is the area where you get basal cell carcinoma. Kaposi sarcoma is mucosal surface, mouth, conjunctiva, also the skin is involved. Squamous cell carcinoma wherever there are squamous cells. Okay, the other option was multiple myeloma. Why cannot it be multiple myeloma? Again, this is a pigmented tumor. Okay, so the tumor will usually be, it's a melanocytic proliferative tumor, right? So they usually be black in color. So here it was not a melanocytic tumor. Okay, so again your multiple myeloma is ruled out. What do you see on histology in multiple myeloma? You see prominent eosinophilic nucleoli. So this is a question. Basal cell carcinoma, you see peripheral palisading with surrounding clefting. That is a question. Next question. So iska answer Kaposi sarcoma tha, no confusion. Next question is a young adult. This young adult is presenting with hematuria. Okay, child. Some said ma'am it was child. Some said ma'am it was young adult, and some said ma'am it also had a cola colored bleeding in the history. Okay, some said only hematuria. So please clarify this. And there was history of upper respiratory tract infection. Okay, creat was 2.2, now has become 4.4. Agar, so this entire answer is based on this one line. If they are saying that it was something which has deteriorated or rapidly progressed, then it becomes RPGN. This is a clinical scenario, okay, where it is a rapidly progressive type of glomerulonephritis. If this was the answer, then what is the likely kidney biopsy? Would have become crescents. Okay, slight confusion if they have not mentioned this. If they have just mentioned that creat was 4.4 and they have not mentioned you about deteriorating creat, and they are just telling you it's a young adult with a respiratory tract infection and hematuria, which means they are asking you to mark the diagnosis becomes PSGN and your answer would become subepithelial deposits. Otherwise, this is a crescentic RPGN. RPGN, you have anti-GBM, okay, and you have immune mediated, which is post-infectious. So that is your post-infection, or it can be post-immune mediated, okay, your ANCA associated. So this becomes, if this was given, the diagnosis is RPGN and it is crescents would be the right answer. Next question, this is a child or a patient, we don't know, whatever it is, presenting with a rectal mass, and the rectal mass is like this. It's a polyp, it's a rectal polyp, and this polyp, okay, has colonic mucosa which is filled with mucin. You are seeing colonic glands here which are dilated and filled with mucin. What is the diagnosis? So here they are talking about juvenile retention polyp. Okay, in children, if the history is at children and polyp, then you only have Creutzfeldt's polyp or you have juvenile retention polyp. Now juvenile retention polyp is associated, it's a hamartoma. Remember, it's a hamartoma and it is associated with juvenile polyposis syndrome, which is autosomal dominant. And here you have your Christmas tree pattern. Okay, and here what you see here, you see cystically dilated glands which is lined by colonic mucosa, and there is a lot of mucus. They usually present with hematochezia, that is the presentation. If the history is also telling you there is blood, then this is juvenile retention polyp. And the answer here becomes hamartoma. Easily, even if you didn't know this, you could have ruled out the other option. Kya metaplasia kya hai? When one epithelium is changed into other epithelium. Where do you usually see your metaplasia? In your Barrett's esophagitis or your cervix. Okay, so all these are places where columnar metaplasia happens. Here squamous metaplasia happens. Okay, so this is your metaplasia. One type of epithelium which changes to the other type of epithelium. यहाँ पर ऐसा कुछ नहीं हो रहा है. There is rectal mass and colonic mucosa only. So you can rule out metaplasia. Okay. Next is your adenoma. What is adenoma? Adenoma is proliferation. It's a tumor. It's a benign tumor due to proliferation of glands. Here they have not mentioned the word proliferation of rectal glands. They're just saying there is colonic mucosa and mucin-filled cysts. Okay, so adenoma is again ruled out. Could it be choriostoma? What is choriostoma? Choriostoma, dermoid is your example for choriostoma. Choriostoma is when normal tissue occurs in abnormal location. अगर यहाँ पर आपको bone आ गया होता, so if you had seen bone or cartilage here or lot of nerve proliferation or glands here, salivary glands, acini, then it would have become choriostoma. Okay, here what you saw was no metaplasia, no adenoma, no choriostoma. So the answer became, so the option automatically became, so this option automatically becomes hematoma. Okay, let's move on to the next question. Now this question, vitamin K dependent factors, clotting factors are given. So the question basically said there is something which is vitamin K dependent factor. So the other options we could not recall much. So what is the correct answer for this? This is vitamin K dependent factor 2, 7, 9 and 10. So please let me know the other options if you people have recalled and recollected it. Okay, simply why this is the answer, they were asking and testing you about the vitamin K dependent factor. Now you know this mnemonic, not made by me, this is an age-old mnemonic. 2 plus 7 is 9 and not 10. Okay, 2 plus 7 is 9 and not 10. So all these are vitamin K dependent clotting factor. Now you need to know this vitamin K cycle, where it comes in your clotting cascade. Okay, and how it is processed in the liver, and this vitamin K will activate these factors. So vitamin K activates 2, 7, 9, 10. Along with 2, 7, 9, 10 also protein C and protein S is activated by your vitamin K. Okay, and here on your reductase, here to inhibit this, what is the drug which acts? Warfarin. Okay, your anticoagulant is warfarin which acts there. Now moving on to the next question. This was a 22-year-old male. He had a history of some chest surgery, and he has developed this kind of lesion. So what is the option? We couldn't get much recall, but everybody said एक keloid question था ma'am, जिसमें previous history of surgery was there and the scar was there. So the answer is keloid. Please let us know the other option. I'm sure hypertrophic scar would be one of the option, but anyways, so this is the gross appearance of a keloid. So the answer here became keloid. Next, age-old, very important question. 5-year-old male patient presenting with fever and left ventricular dysfunction. Image is given. What is the diagnosis? This was acute rheumatic fever because they showed you a Ashkoff body. One of my students told me, ma'am, it was just a lymphocyte cluster. If that, then you could mark lymphocytic myocarditis. Okay, but here if they're telling a child and they're telling fever and heart dysregulation, then dysfunction, then I think they're talking about rheumatic heart disease here, and the right answer becomes acute rheumatic fever. Now, if there were a lot of eosinophils here, okay, then it becomes Chagas, which was not seen. Pyogenic myocarditis, again a lot of neutrophils would be seen, again that is not seen. Okay, so the answer is simply acute rheumatic fever. So when it comes to rheumatic heart disease, again a high yielding topic, you should know everything thoroughly. Okay, how many weeks later they present with this, and it is a pancarditis picture. This is also important. It is a pancarditis picture. All your layers, your endocardium, your myocardium and your pericardium is involved. What do you see in pericardium? Fibrosis. And what do you see in your myocardium? You see this Ashkoff bodies. Ashkoff bodies. And Ashkoff body was discovered by Ludwig Ashkoff. And what are these? This is a type of a granulomatous
do with giant cell. Okay. And what else do you see? You see Anishkov cells, which are your caterpillar cells. That is also important. Okay, your caterpillar cells or your Anishkov cells are seen. Okay, one more very important thing about this particular thing is you also see vegetations along the line of closure. Vegetations along the line of closure. Along the line of closure. That is also a closure. That is also a question. Okay, and what is McCallum's patch? What is McCallum's patch? Okay. Left atrium, what is that? So all these are important uh, topics in your rheumatic heart, important headings where questions are usually framed for your need. So this is the next state and it's the only question from your neoplasia. Okay, very strange question, not strange, but quite unexpected question. Okay, Phlenorchus caescens is associated with which cancer? Now, what is this? This is your oriental liver fluke. Okay, it is a trematode. Okay, oriental liver fluke. It is a trematode, and it is associated with your cholangiocarcinoma or your bile duct cancer. Okay, and what is this? This is a how does it belong to neoplasia? It is a biological carcinogen. Okay, biological carcinogens are very important. So your biological carcinogens. Okay, can you so let's see this life cycle now. This particular trematode, this liver fluke, this snail. Okay, the snail is the primary host. Your fish and your sucker fish becomes your secondary host or your intermediate host, and man is the definitive host. Okay, man is the definitive host. So resulting in, and again the feces passes and again goes on to snail. So that's how the life cycle continues. You need to know if they ask you this. Coming on to biological carcinogens, you need to know few biological carcinogens. H. pylori, all of you know, associated with gastric cancer. Aspergillus species associated with liver cancer, aflatoxins. Your candida is seen to be associated with oral cancers and lung carcinoma. Schistosoma hematobium, again a age-old high-yielding question associated with bladder cancer. Okay. HPV associated with nasopharyngeal, cervical, penile carcinomas, anorectal carcinomas, all your genital urinary carcinomas. HBV, hepatocellular, NHL, breast. EBV, nasopharyngeal and Burkitt's. We just discussed this. Okay, and your HIV is associated with lots, and your especially Kaposi sarcoma is your HHV. So this is all these. What are these? These are your biological carcinogens. Biological carcinogens. Okay, microorganisms which promote carcinogenesis. Now, the next question. This was a 45-year-old cement industry worker. Cement industry में काम कर रहा है, which means he is being exposed to asbestosis fibers. Okay, asbestos fibers. Also, another clue was here mesothelioma. This is a straight question, easy question. Asbestosis was the answer. So many questions if you have attended the last two high-yielding topic clinical MCQ session of mine, around 4 to 5 questions topics we had discussed, and I had told you pneumoconiosis is a very important topic, and we had discussed silicosis. Never mind, the question was asbestosis here. Okay, so asbestosis, your pleura is usually involved, and you have pleural plaques, you have pleural fibrosis, and you have mesothelioma, very rarely lung carcinoma. Okay, so this answer here was asbestosis. Next question, again quite simple. So they had given you a picture of Gaucher cells. What is this? This is Gaucher cell, which is your crumpled tissue paper. Okay, all of you know this. And they had asked you which enzyme is deficient in this disease, Gaucher's disease. So the answer is glucocerebrosidase. This is again an age-old MCQ, right? So all of you, I think, would have definitely marked this. Okay, glucocerebrosidase is Gaucher's, glucose 6-phosphate deficiency is your von case, alpha galactosidase is your Fabry's disease, and your hexosaminodase is your Tay-Sachs and or Niemann-Pick's disease, depending upon the subunit. So this was a straight question, but now they also got very smart. They are also asking you what metabolite is deposited. That also you need to know in these things. Okay. Anyways, so this was an easy, no doubts in this. Glucocerebrosidase was the answer. Okay, Gaucher's cell. This is seen in the bone marrow. Okay, in a bone marrow aspirate, you see these kind of cells, and these are storage disorders. Which is true regarding Mendelian law. So this was a zara hatke wala question. So the answer here is 2/3. So this Mendelian law of you have law of dominance, law of inheritance, and law of segregation. Okay, and what does the law of dominance say when two heterozygous there is permutation and combination? Then they have seen that according to his pea plant experiment, about 50% is autosomal dominant, and when you divide this, it becomes around 66, and this is the closest option, and that's why we are considering this as the answer. If you feel no, this is not the answer or something else is the right answer, please type in the chat box, and if these were not the options also, please let me know. Okay. Moving on to the next question. This was an alcoholic with history of jaundice. Okay. So, and his ALP is raised while his AST and ALT is normal. So, when they are giving you this history, saying these two are normal, which means you can easily rule out cirrhosis and alcoholic hepatitis. Now, what is the most probable diagnosis? Cholangiocarcinoma, usually everything is normal, or in cholangiocarcinoma, all the three are raised. Okay, normal or all the three are raised. So the answer over here is obstruction, and hepatocellular carcinoma becomes the right answer. Okay, this is liver ALP they are talking about. ALP is raised, can be kidney ALP, can be pancreatic associated ALP. So all these things we will discuss in detail when we read. So the answer for this question was hepatocellular carcinoma. Now the next question. So this was breast carcinoma, and which of the following is a good prognosis? So they have shown you breast carcinoma, and they are asking which of the following is good prognosis here. Now, so something that you need to know is in your breast carcinoma, you have BRCA association. What happened to my pen? So you have BRCA association. Give me a minute, students. So you have BRCA association, and you have, so if it is BRCA associated, remember they carry a bad prognosis. Okay. Now ER positivity has targeted therapy, and it is a good prognostic marker. You have triple positive. So whenever now, before they used to send a specimen of breast cancer, and pathologically they used to give a score called as Bloom-Richardson score or the Nottingham score, and based on the amount of atypia, based on the lobule formation, they used to give a total score, and based on that they used to grade the prognosis. That is old now. Now they do something called as hormone receptor status. Okay, hormone receptor status, where they check ER, PR, and HER2 positivity. And because these have a good targeted therapy, whenever good targeted therapy is available, which means they become good prognosis. So ER positivity automatically becomes a good prognosis. P53, of course, is a policeman, and if it is found to be muted in some cancer, it carries a bad prognosis. Ki67, this is a so if the cancer is aggressive, or if they are proliferating largely, then Ki67 is very high. Okay, so the more Ki67, the more it is proliferating, the more it is multiplying, which means it is a bad prognosis. Okay, so this again, Ki67 positivity makes it a bad prognostic carcinoma. So the right answer over here is ER positivity. I think I've made myself clear, right? Okay, so this is the last question. So this particular male patient has come with hyperthyroidism, and the image is shown. So this is a photo. He has exophthalmos, and what were the antibodies associated? So this was Graves' disease. So this was Graves' disease here, and they were asking you about the antibodies. So the correct answer over here is your anti-thyroid stimulating antibody. So the correct answer over here is your antithyroid stimulating antibody. Sorry, I'm not able to mark this, but this is the right answer, antithyroid stimulating antibody. And why? Because this is, if it was Graves' disease is usually associated with this particular antibody. So you just had to diagnose and you had to mark which antibody are they talking about. Okay, so this particular option B is the right answer, antithyroid antibody. You should know what antibodies are seen in Hashimoto's disease, what antibodies are seen in Graves' disease, and what is seen in your atrophic thyroiditis. All these are autoimmune thyroiditis, again very important, right? Okay, so I hope all of you have done the questions well. And please type in on the chat box what you feel, or what you can please add on to the questions and the options. And even if you feel, no ma'am, I think this was not there in the question and this was there, please let us know. Okay, fine, thank you.